Okay, welcome everybody to the ICB board in public. As I think you all know, this meeting was due to take place in Twickenham, but because of planned industrial action affecting train services in South West London, we decided earlier this week to take the meeting into a virtual space. Apologies for that, but I'm sure that people will understand why we needed to do that in order that we could actually have a quorum meeting. Just a reminder, this is a meeting in public, not a public meeting, so we won't be taking interventions from the public. Indeed, we will take written questions from the public at the end of the meeting. We don't have the capacity, however, to take any live questions, so apologies again for that. Just a note for everybody, this meeting is being broadcast online and a recording will be uploaded onto the ICB website after the meeting. Will ensure that a version with British Sign Language is also produced. I'd like to say a couple of welcomes and farewells. I'd like us to pass on as a board our thanks to Dagmar, who stepped down from the board as place member for Merton. Her contribution not only to the ICB last year was really significant, but she has been a really valued partner across South West London for a number of years. Just to alert people, the nomination process will be started for the Merton representative, and we hope to have concluded that in time of the next formal board meeting. I'd also like to give a big welcome to Elaine Clancy, which this is her first ICB meeting as our chief nurse. Elaine, do you want to say a few words?
My first challenge is the technology, Mike. Thank you. Yes, I'm delighted to be here. Really privileged to have been appointed and delighted to be at my first board meeting. I'm week 3 in, so enjoying it and delighted to be here. Thank you.
Mike, you're on mute.
A big welcome to you, Elaine. And we're all really pleased that you've joined us. We're all really excited to be working with you in the months and years ahead. We've had some apologies for this meeting. The first from Ian Dodds, place member for Richmond. The second from Matthew Kershaw, place member for Croydon. The third from James Blythe, place member for Sutton. Then Kelly Palmer has also provided her apologies, and she's the partner member for Specialised Services. And Karen Broughton, Deputy CEO, has also provided her apologies. I am aware that Ruth Bailey will need to step out of the meeting briefly at around 10:40, but we hope that Ruth will be able to join us for the rest of the meeting shortly after that. I don't think there's any further apologies. And I know that the meeting is quorate, so I suggest that we move on. Could I first check on declarations of interest? These are posted on the ICB website. They're included in the pack of papers. Just to check with colleagues that there are no additional interests. I've not been alerted to any in advance, and I'm assuming that's the case. Fantastic, thank you. We'll move on to the minutes of the ICB, which was held on the 28th of June. I don't propose to do a page turner here. I'm sure everybody's had the opportunity to read those minutes, and can I just check that people are content to approve them? I'm seeing lots and lots of nods, so we'll take those as approved. There is an action log attached to the minutes. There are no items which are due to report at this meeting. Can I just check that there are no updates that anybody would like to provide? No, that's fine. We'd like to talk about decisions made in other meetings, particularly the Part 2 meeting, and I'm going to go across to Sarah to update the board.
Thank you, Chair. So just very briefly, the board met in private to sign off the draft annual accounts and annual report. We had to sign that off before it was submitted to NHS England for their review, and it will be published in September prior to the AGM. So the public will be able to see the finalised documentation after it's been reviewed and signed off by NHS England. And I think that's probably all I need to say on that, Chair.
Thank you, Sarah. We'll move on to the Chair's report, and probably just worth noting the sad events in Wimbledon a couple of weeks ago with the tragedy at the local school. A big thank you to all of our colleagues in emergency services, in all of the emergency services who stepped in to provide support at that tragic time. In terms of the Chair's report, there's a written report attached. I think it's worth just drawing out a couple of areas from that. The most notable, I think, is almost certainly the NHS 75th anniversary. And I know that there were celebrations across Southwest London. I think that the New Springfield site celebrated with a street party, which puts a real focus upon their place in the community. And I think it's also worth noting Windrush 75, the 75th anniversary of the arrival of Windrush. And the two are connected, particularly for us here in South London and South West London. The original Windrush arrivals were placed in a reception centre in Clapham. And from that reception centre in Clapham, many of those went on to work in our South London hospitals, particularly George's and St Thomas's, and some of the hospitals that no longer exist in our part of Southwest London. A really valuable part of our workforce, and I think it's really important to note the ongoing contribution of our overseas workers and those people who have settled in the UK to the success and the ongoing future of the NHS. So really worth noting those. Two other things I'd really like to draw to people's attention again on the celebratory note is we had Pride throughout June, and that was a big Pride celebration at the beginning of July. I know that there were many NHS and local authority and community organisations from South West London represented on the Pride Parade, which is fantastic to see. And of course, many of our staff and the communities we serve celebrated Eid during the recent period. So again, just to note that. The paper outlines the process that we'll have for the AGM. We'll be announcing the date towards the end of September, for that meeting at the end of September, and at that meeting we'll be presenting our annual report. We've also completed work on our ICP strategy, and I know Ruth will want to share celebrate that and give us an update in her report further down the line. So we'll move on to our update on ICS Digital, and John Byrne, our Chief Medical Officer, will speak to this item. He'll be supported by Martin Ellis, our Chief Digital Officer, and Matt Laundy, our Chief Clinical Officer. John, I believe that you'll be orchestrating all of the contributions, so I'll go straight across to you.
Yeah, good morning, Mike. So we got some feedback. So give us a second, we'll fix it. First technical task achieved. Is that better? Or is it still an echo? Okay, I'm getting it.
John, it's fine. It's good.
Okay, thank you, Mike. Look, thank you for the opportunity to bring digital to the meeting today. It's a huge subject. It's as broad as it is deep, and it means different things to different people at different times. So whether it's the laptop in front of you and trying to struggle with the sound and the mute buttons, to how you access your own healthcare, to how you book an appointment, to how we use your data, to how we communicate, and then the emerging things around sort of artificial intelligence, what that would mean. So what we've done today is just Martin and Matt has brought a presentation, brought a paper just to go back to some of the basics Mike, because we've been worried about cyber and things like that over the past 2 years and some of the infrastructure issues. So we will talk a little bit about innovation and demonstrate some of the innovations that have taken place over the last couple of years and actually what that means in reality for clinicians and patients on the ground, particularly around the shared care record. But we particularly wanted to touch on some of the basics of the infrastructure stuff, which might seem like a dry subject, but it's when things go wrong with regard to infrastructure and cyber that we all start to get excited and animated, to say the least. So we will touch on some of that, because nationally we've had some challenges with regard to cyber over the past 18 months as well, historically. So I'll try not to steal too much of Martin's thunder and Matthew's thunder either. So I'll just pass over now to Martin, who is Chief Digital Information Officer for South West London.
Great, great. Thanks, John, and good morning, everyone. And thanks for the time today to discuss digital across the ICS. So we put together a short paper, which I assume you've had a chance to look through, and I've created a few slides just to sort of bring that to life, which I'll go through in a minute. Then what we're going to do is Matt, with support from one of the technical team from Kingston, are going to demonstrate the London Care Record, which we're part of, which I think is really a really big sort of step forward that we made in South West London, which is really supporting how we care for patients on the ground. So let me just share my screen. Let me know when you can see that.
We can see it.
Brilliant. Okay. So this is a double act between Matt and myself. So just as John's talked about, there's some sort of key things we need to do around digital infrastructure just to make sure, what we do, across South West London is on a sound footing. And when we talk about digital infrastructure, we're talking about things like data centers, networks, so broadband, Wi-Fi, that sort of thing, and this kind of medium that we're on right now is digital infrastructure. So understanding that from an ICS point of view is really critical. So we've commissioned sort of 3 pieces of work which we've been working on for the last 4 to 5 months, which is to understand the position across South West London as best we can. So essentially gathering intelligence around how robust is our infrastructure. So we've been using what's Infram, which is it's kind of like a international standard around around infrastructure. We've been doing a maturity assessment of the hospital sites against that, and it's a sort of internationally renowned process to do that. We've been looking at cyber security across the key providers in South West London. That's ongoing. We've got BT supporting with that. We've got extensive experience in cyber security management, and that's almost complete, that piece. And we're also doing a piece around what are the opportunities for cloud-based hosting for our services. So those 3 pieces, when they come together, will give us some really good intelligence that we haven't had in the past to understand where our strengths are in terms of infrastructure and where our weaknesses are, more importantly, and how we need to invest in those going forward if we need to, or prioritize our investment towards. So that's a really strong piece of work that's ongoing, and be able to feedback later in the year on how that's progressed. In terms of sorry, I've jumped a slide. Apologies for that. Because what really is driving all of this are sort of 4 key areas. So obviously we want to support the aims of the ICS, so improve outcomes, tackle inequalities, enhance productivity, and support local economic development. There's also the national What Good Looks Like framework for digital and IT across ICSs. So is it well led? Do we have smart foundations? And I just talked about infrastructure, which is really what that's about. Do we do this safely? How do we support people and empower our citizens? And do we have capability to promote healthy populations and use digital to drive improvements in care? We developed a digital strategy in South West London that was signed off in 2021 by the predecessing governance to this board. And it focuses on the 5 key areas of digital infrastructure, shared care record, population health, personal health and care record, and innovation. And more recently, NHS England, to support sort of how we recover, in particularly in acute, have prioritised 6 secondary care digitisation priorities. So system control centre, how we understand where the pressures are in the system, how do we understand in live form what's happening with bed management and beds, how how do we get the most out of digitised records, getting the most out of waiting lists, so refining waiting lists and optimizing the use of theatres, understanding discharge and making sure discharge can be as efficient as possible, and using AI to be able to support in multiple ways. In the last year, I was appointed as CDIO last year, and I've been driving the delivery against all of these key drivers, and have been driving sort of setting up a collaborative approach across South West London. We have a weekly forum with all the CIOs in the system, where we talk. It's partly structured, partly unstructured, where we talk about the real issues, and we bring teams together on that. And then that's overseen by the ICB Digital Board, which has membership from stakeholders across the ICB and the ICP. So we have Alyssa, for instance, is on there from Healthwatch. We have representation from the third sector, etc., and from local authority. So, and in fact, if you look at what good looks like framework, by also establishing good processes to manage this, we tick a lot of boxes in the well-led what good looks like. So that's, we're doing really well there, I think. So just going back to that slide I was on previously, so talked about digital infrastructure, personal health and care record. We're blazing a bit of a trail really in South West London in terms of how patients can interface with acute hospitals. So we've got 3 out of our 4 acute hospitals in South West London already have technical capability for patients to be able to view and change their outpatient appointments. And we've been lucky enough to win more money recently to be able to extend that capability to look at how people can look at diagnostic appointments, etc. So we're building on that capability that we have. So, and we're kind of fairly unique in London with that. There's Royal Free, I think, is the other trust that's got that. But that's a national push to utilise the NHS app as the front door for the NHS, and this connects through the NHS app. South West London St George's is also working with South London Partners, a partnership across mental health, to implement a personal health records that support patients with mental health. So in terms of innovation, so these are the sort of delivery against the strategy, as I said earlier. South West London working with, we're looking at running a innovation conference later in the year. So we're working with South East London colleagues and the HIN to look at setting up a day where we'll bring together people from the front line and the industry to start to look at, okay, how do we get the best out of some of the things that we already have? What are the latest sort of innovations that might help us in delivering better care and doing that more efficiently and effectively? So that's something we're planning to get up and running, and we're launching this Friday, the first day of the South West London Digital Pioneer Fellowship, where we've got 40 members from across the ICP who are engaged in a year-long program to develop skills around digital transformations. And they're all working on a digital project in their own field. We've got 8 people from local authorities involved in that. We've got from variety of settings within South West London, and I think that's really exciting because it develops skills for individuals, but it also creates this network across our system, which I think some people struggle with at times. So we're really opening the door, and I think it's quite supportive of what we're trying to do across an ICS and an ICP. Population health there's been quite a lot of work on in terms of developing that over the past year or two, and we've developed a data strategy with which is not, and I will bring that back in when it's complete. We've got the first two parts of it, which is the what and why. So we've developed a really strong and ambitious strategic intent for data. We're now working on the delivery plan for how we would go about that. So I really want to bring that back because it's very exciting. I think there's this immense amount of data in across health and social care that we just don't utilize very well. And so with input from 80 people across the system, we've been able to say, this is strategically what our ambition is. And now we're working through, the delivery plan for that. The fifth part of that, the North Star from our digital strategy, is a shared care record. So we've had a shared care record in London, in Southwest London, for a little while now. But over the past year, you can see on the picture on the right, there's a Southwest London hub. We had 3 of those. So we merged those 3 together. This new hub is hosted by Kingston. It's an upgraded version and it's got better connectivity. It sits within the broader London infrastructure for a shared care record. So we're part of a London-wide shared care record. Essentially a professional that's got right to see that will be able to see the details from anyone across London. And that benefits hospitals, community providers, adult social care providers, GPs, and out of hours. In terms of adult social care, we've tested it with a dozen care homes who have been able to get access to this as well, and they found it really beneficial. So we're now looking at how we might expand that. So I had this slide because it kind of leads into the next bit, which is a demonstration of this. So I'm going to hand over to Matt to do that. And then after that demonstration, we'd be happy to take questions.
Thanks, Martin. Over to you, Matt.
Matt, we can't hear you if you're talking.
Can you see? Sorry, I somehow muted myself. Okay, so just following on from Martin. So my name's Matt Laundy. I'm the CCIO for the Southwest London ICB. And I also introduced Sam Kelly, who's the lead for the London Care Record within the Southwest London region and sits within Kingston, who's the lead provider on this. I know Martin's done a diagram here. I just wanted to bring it into its context. So the London Care Record, it allows organizations to share information. So it's not a pulling system, it's a sharing system. The different areas such as acute care, primary care, social care, community health, etc., all share information through the London Care Record, either directly or through the local records. There's lots of terms that are used interchangeably. Sometimes they mean slightly different things, but on the whole, they are at the moment all the same thing. So you may have heard the word shared care record.
Matt, if I just ask, we've all got blank screens, I think.
Have you? Oh, it's funny. I can see.
If you ping it to me, Matt, I'll share it.
Hold on, sorry. Let me try one more time and then I don't know why it's not. Can you see that?
Yes.
Okay.
Yeah.
I'll leave it at that rather than doing a full screen this way you can see. So as I say, people allows organizations across London to share the data. There's these different terms which are used interchangeably. The shared care record Martin used. The London Care Record is how we branded it, and there's the name that we're going to carry on using because it's become quite confusing. There was Connecting Your Care, which was a local Southwest London initiative, which sort of kicked this off in Southwest London, and that is now being superseded by the London Care Record, but some people still know it as that. A longitudinal care record is another term. And then the final term is health information exchange, which is a lot of the clinicians within hospitals know it as such, even though that actually is a technical description of what it is often used interchangeably. So if you hear these terms, these are all pretty much the same thing at the moment. So what does it offer? It offers documentation, whether it's discharge summaries, clinic letters to clinicians and other interested parties across the health and social care system, information on conditions, medication, allergies, labs, etc., etc. And this so it allows people to see this information from wherever they are in terms of providing care. Now, Sam's going to present what it looks like. It'll be coming in from a acute trust perspective, but pretty much what they see, everybody else sees, including the care homes. Now, Martin mentioned that we got it in a few care homes at the moment. There is a wider piece under NHS London, One London, to roll this out to more social homes, and especially to integrate it with their patient management system, so it all becomes integrated. So without going on much longer, I'm going to hand over to Sam now, who's going to demonstrate it. Sam is demonstrating because obviously we have to use the test environments. I got access to live, but we're not sharing live patient data, and so I'll hand it over to her.
Morning, everybody. I'll just give me 1 second to share my screen. Hopefully it will work.
While we're waiting, what I also wanted to say was that it has changed the way we work as clinicians to be able to have this information to hand rather than relying on secondhand information, misremembered information. I take a little white tablet from my GP. I can't remember its name. It's all there now. Makes a huge difference and for patient experience and safety.
Okay, so this is the view from the acute trust. So this is obviously a test patient. How we cover IG is by going through each EPR. So most organisations will have their own EPR and be able to have access to the London Care Record. You click on to your EPR, and the first thing that you'll notice that comes up is a disclaimer. So as was mentioned by Matt earlier, this is all of the information on here is shared, and what is shared on here is decided by each organisation. We don't pull data, it's shared. Once you go onto the page, the landing page, you have, I'll explain the red banner across in a minute. You have different way of viewing it. You can just so, because a lot of people, when they first look at this, go, oh, wow, this is overpowering. There's a lot of information on there. So you can look at it within the amount of days. You can also see all of the records that are shared. So you can see what hospital or organisation you're looking for. You can change the front by looking at 1 or 2 columns. You can also move the tiles around. So if you're a GP, you're not going to need to look at your own systems information, but you can have a look at things that are normally the things that you're looking at, whether it be in your clinic or in your social care, etc. These are just the codings. They're more for background stuff. And it also, oh, that's not working at the moment. It's just a test, so sorry, ignore that. So what happens is when you load it, it comes on to the loading partner. So it needs to get to 100% for you to be able to see all the views. You can also do a search. So if you're looking for a specific liver function or anything to do with that, you can go up and it will bring up any of the tests or anything like that that has a specific mention of liver. Obviously, I'm not clinical, so excuse me. You also have to make sure that you clear all of the filters once you're searching, because otherwise you won't be able to go on to other parts. So you've got all of the information here, and I'll see if I can clear the filters, which will help. No filters. So you've got clinical correspondence, You have encounters, so people go into what organisations. You also have GP records. Now, with the GP records, you do not see into anybody's GP records. You only see what they want to share. So you do not see the content of a visit, only if they've requested investigations or if they're blood tests or even if they've been to see their doctor the week. So if somebody presents at ED and you've already requested, or there's already been a blood test requested on a Friday, and on the Saturday somebody will know to look at the results, therefore saving having to repeat those. You've got radiology reports, nothing, there's no actual imagery at the moment, but that's being worked on. You've got the social care, you've got community as well, community nursing, and that at the moment is coming up in social care, but in live it doesn't. So this is the Your Healthcare information, and this is the London Borough of Sutton. So this will give you a rough information of the details they're offered. Now, this is very sketchy at the moment. There's some work that needs to be done with the local authorities on what they're willing to share. So sometimes it can be a bit brief.
Sam,
so
thanks. Sam, it's Martin. Thanks. I mean, it's been really helpful just to give the board a sort of an insight on the depth of information that's available on the London Care Record. We could probably take the screen down now. Thank you for going through that for us.
I was just going to show the UCP, the Urgent Care Plan.
Okay, and then I guess if we
just
can
very quickly.
Thank you.
If there's a red banner, you can go down and have a look into the Urgent Care Plan, which has recently last year been implemented, which gives you into end of life information.
Okay. Well, thanks for that. Thanks for doing that for us, Sam. So I'm conscious. Do people understand what Matt's role is? Maybe Matt wants to explain what his role is at CCIO.
Well, that's a $1 million question. I suppose my primary role is to provide clinical expertise and experience into the digital process, to act as the intermediary between clinicians and the digital team, to guide strategy, which has been set up by the ICS, to provide a point of contact. There's multiple mini roles that I do, and to be part of the member of the team as well in terms of actually delivering. My main things at the moment is helping with the Southwest London Digital Pioneer Fellowship, which, as Martin mentioned, starts on Friday, and we're very excited about to sort of build that community across Southwest London, which at the moment it's fragmented because and there's lots of good stuff going on, but not everybody knows about it. So it'd be really good to start to build up that community. And I have a problem. I know that somebody else is doing it over there, to go there, and moving away from that sort of hackney term, but silo working, which we all know is true, but we all repeat it, but sometimes we are difficult to break it down.
Okay, thanks, Matt. So thank you, everyone, and we'll hand over back to you, Chair, for questions.
Thank you for that, Martin, Matt and Sam. I think really helpful to see digital is right at the heart of our plans for Southwest London. If I go to Mike Jackson, first of all.
Thanks, Mike, and thanks for the presentation. I mean, there is some really good collaborative work going on across the system on digital, including local authorities. But I have to say, it didn't come through as strongly as I would have hoped, either in the report or the presentation. The shared care record is a really important part of that, and it's great to see it coming to fruition. It's been something of a holy grail, hasn't it, for health systems all over the country, and it looks like we're making real progress on that. But there's not a lot in the strategy, and we didn't hear anything in the presentation about tech-enabled care or anticipatory care. And data and digital is critical to enable us to progress those agendas. And there is work going on into that across the system, and I would have liked to have seen more of that in both the strategy and in the presentation. So perhaps that's something we can give more emphasis to going forward. Thanks, Mike.
Mike, thanks for that. And I'm sure I'll come back to Martin after we've taken the comments, but I think we could probably feature digital at most of our board meetings on the basis that it is so central to everything that we're doing, and every aspect of our work will be digitally enabled. So we'll probably need to come back to that on other occasions. But let me take a few more comments. If I can go to Jacqueline.
Morning. Thank you very much, Martin, Matt, and I think, was it Karen, the other person?
Sam.
Sorry, Sam. So as a patient, I use the app, and I find it really helpful, and I get all my appointments, and I can see all the letters that have been said about me rather than using the post. So I really enjoy using it. But I suppose my question just about the IT and digital going forward is that the NHS is an organisation which is about people, both the patients and the staff. And one of the biggest issues we have in getting things rolled out and adopted is how we engage with the people on the staff side who use it. And I know Matt, to his own cost, will know that being CIO at George's often was coming up against people's own views and prejudices about using this. So the first question is how are we engaging the right people around the design and implementation? Because it's not an IT project, it's a change project. And the second bit is we are trying to work and step together as South West London. And I suppose the bit here is sometimes not all of our teams think that's right, and they go back into their own personal domains or hospital or healthcare or social care domains. I'm just wondering how we use us as chief execs to try and help move through some of those sometimes different opinions where people might protect their own organisations for the when we want to get the benefit out of London, out of South West London. I hope those are all right, having those two questions, Mike.
They definitely are, Jacqueline. They're great questions. I'll take one more intervention at this point and then go back for some comments and answers. And then Nicola and Elisa, I'll come to you. But Zara, could I go to you next before we go back to the team?
Thank you. Hi, Martin. Sarah, I'm the director of the South West London Voluntary and Community Sector Alliance. So my comment really is about the voluntary sector, as you can imagine. I would like to see the voluntary sector embedded in your work around digital innovation a bit more. There are so many things that our communities can support you with. For example, they can play a substantial role in empowering communities that are not normally using technology, in assessing, health and care data, in booking appointments. And there are community hubs already in place, and with very little investment, I'm talking very little, you can actually reach out to communities that you wouldn't be able to reach out normally. So I know we have a rep, on the digital subgroup, but I think it needs to be a bit more strategically embedded into your plans. I couldn't see much into the presentation about it. Yeah, thank you so much.
A great point, Sarah. So Martin, do you want to field those questions?
Yeah, thank you. And I guess what this demonstrates back to me is that it's really great to be here today to be able to understand what's important to everyone. There's such a broad there's such a broad piece of work. We're in every area, and to bring a sort of update on everything to this board is really very difficult. And so, as you say, Mike, regular updates might be needed to focus on different areas because there's so much going on across digital that we have to keep an eye on. In terms of the questions, so Mike, going to your question around tech-enabled care and anticipatory care, both things close to my heart. I led on the anticipatory care with Annette in Kingston and Richmond, and we put digital solutions in to support that. both from how you use data to identify people who are got rising risk, but then how you also have a digital solution for people who are supporting that individual, including the voluntary sector, to be able to collaborate together around that individual, because we all have different organizations with different IT that doesn't work together. So we've worked on a digital solution that can ride across all of that. So that's really exciting, but to be able to do that. So happy to give more info on that as we go forward, but also tech-enabled care. That for me is a huge opportunity for health and social care to come together on, because if you think about the people who are having who traditionally on telecare, they're probably the same people who would fit in, there's a big overlap of people who would fit into anticipatory care in that space, or who have got problems discharging because they have their frailty has risen, their frailty score has risen, etc. So I think there's a big opportunity of tech-enabled care. The other factor is also that BT's been told to turn off analog phone lines. So telecare for 20,000 people who get telecare right now runs over phone lines. So all local authorities across the country are looking at digital solutions. So we should be doing that together, collaborating on that. So I think there's a big opportunity there. Jacqueline, your questions around how to engage people. To be honest, I don't want digital to be the tail wagging the dog. It has to be the other way around. These have to be transformation programs that we support. We're central to that. But we come in at the beginning. I've created a role. You probably know Ian Frost. I brought Ian Frost into my team to be able to help with that, to get up front in the transformation projects and say, well, digital can and can't do this, and we can help you sort of with digital solutions to support your transformation, because there's much better uptake of digital if you can do that. And in terms of South West London versus trust, we've been doing a lot of work in sort of building up relationships with CIOs, but it goes broader than that, obviously. I think the financial recovery plan will help start to break down some of these things, because we're going to have to collaborate on some things, and we've got specific areas around digital which we're going to have to work through. So it's kind of work in progress on that. But I think that's kind of we'll start to we'll start to understand how well we're going to collaborate through that process. And then, but I do think there will be challenges there because of this pressure on IT departments at the moment to be able to keep the lights on. And then, in terms of Sarah, your point around the voluntary sector, we have done it in projects like the anticipatory care example I gave, but we probably do need to strengthen it. You're probably right in terms of more strategic. So it'd be good to catch up outside the call and to talk about how we can do that.
Martin, thanks for that. I'm going to take a few more comments because clearly this is a really big area of interest. Primary care in South West London, of course, was way ahead of the curve compared to other parts of London. Nicola, over to you.
Yeah, thank you, and thanks to the team for the paper and the presentation. And I do welcome the rather dull but absolutely necessary focus on security, and would add to that the need to ensure our infrastructure integrity and information governance are sound, because our services become unsafe very swiftly if our systems go down, and we really feel the brunt of that on the front line all too often. I completely appreciate that you haven't been able to mention everything. So I just wanted to flag the importance of the work in primary care, because we've got dozens and dozens of digital projects going on in primary care. Part of the challenge is understanding what they all are and where they're all up to, and what the output of them is, and what outcomes there are for patients. We've got development of e-hubs, which are enabling several practices in a PCN to deliver services together, really strategically important. We've got the digital referral pathways that developing between GPs and community pharmacies, which also that could provide all sorts of benefits for patients. And we've got digital resources for patients with long-term conditions. So there's, we've got masses going on. I heard Martin say that digital innovations can drive improvements in care. And I agree with that, but I think we've also got to ensure that the needs of our patients and services drive which digital projects we focus on, because we've got hundreds of providers vying to, be part of this digital endeavour, and we can't do them all. But three key issues for me, really, that our digital innovation must be underpinned by the IT capability we have, because I see that really starkly in our practices, in our pharmacies and care homes. So I'd make a plea to ensure that our IT across the system is robust, on which all this can build. The adoption of the NHS app as widely as possible seems really critical to this, and I think national and local comms to support that will be really helpful. And I wonder, Martin, whether you're working with the comms team on this, and Charlotte's got a hand up, so maybe she can tell us. And finally, digital exclusion. It's a really, really important theme that we've got to pay attention to, because these advances and innovations improve health for our whole population, but more, we want to seek to find ways within them to reduce health inequalities and not increase them. So I just wonder if you've got that on your mind, and how we can make sure that we pay that the right attention. Thank you.
Great, absolutely fantastic points, Nicola, and it is really important to remember how much innovation is going on in primary care as well, because I know it's a real hotbed. Elisa, over to you.
Thanks, Michael. Thanks, everyone, for their presentations. I just want to reiterate what's already been said around the importance of accounting and addressing digital exclusion, and wanted to offer HealthWatch, particularly as a partner in connecting people with the voluntary sector. So maybe if we can be included in those conversations, Martin, with Sarah, I'd really appreciate that. The other thing I just wanted to ask, and it really is maybe a show of ignorance, but do we know where people living within Southwest London are accessing care? Do we know what percentage of people, for example, are crossing the borders outside of London, going into Surrey Heartlands ICS to access care? Because that might have
Oops. Yeah, good points.
Shared records. Sorry, shared care record system. Thank you.
We lost you for a moment there, but we've got the gist of the out of London connections. Charlotte.
Yeah, I just wanted to talk a little bit about digital exclusion, because obviously, and I take the point, there's so much to talk about in the digital agenda, isn't there? But we did do a lot of engagement with our communities for the NHS Joint Forward Plan. So we know a lot about our communities who do experience digital exclusion. And we know, I suppose, it's not just older people. So often we say, oh, older people find it difficult, but it's about people living with dementia, people with learning disabilities, people with sight loss. And we also know that people who are digitally excluded, increasingly this means people are socially excluded, as well as finding it difficult to access services. So we are doing work, and I know it is at the forefront of Martin's mind to kind of think about how we make sure that we include people who are traditionally excluded or experience health inequalities. And a lot of that is about helping those communities get digitally enabled. So, for example, we have the Car Find app, so people experiencing and living with dementia can help find their parked cars using an app. We've got some great work that Wandsworth Council have done with Wandsworth HealthWatch around apps for people with learning disabilities, so the Brain in Hand app and the Autonomy app, which have practical videos and kind of reminders for people with learning disabilities. And indeed, we've done a MenCap. My own team has done a video with MenCap helping people with learning disabilities, showing that community that actually we can enable them digitally, and how helpful it is to do daily tasks like shopping and, you know, getting NHS prescriptions. But I think the really important thing is to respect the fact that not all of our communities will want to become digitally enabled. And I know that Martin and the team have that in the forefront of their mind, that we have to also think about those communities who aren't online. And there is a big piece in Chapter 7 of the Joint Forward Plan around the views of communities, and then how we are reflecting the views of communities in our kind of NHS plan for the next 5 years. And then just in response to Nicola's point about the NHS app, that actually was probably one of our most successful campaigns of last year. It's quite under the radar, and to be honest, we were surprised how successful it was. So, but enabling those communities who are very digitally enabled, we have a huge potential, if you like, for kind of getting to communities who are willing to change their behaviour. We still obviously need to focus on those communities communities who aren't keen on it, but we had huge success kind of getting our more digitally enabled communities to download the app. And we know that a lot of that is around people, because we use a Google search terms function. It's people looking for NHS advice and NHS prescriptions. So using our kind of modern communication techniques, we can help those people understand that the NHS app will be helpful for them to get what they want quicker. So I just wanted to raise that. Thanks, Mike.
A great point, Charlotte. And I'm really, really pleased that we're doing so much in South West London around digitally excluded as well. I think that's really important. I know that we'll come back and revisit that in all of our discussions around digital. I'll take two more questions or points, then I'll come to Martin for any responses, and then I'll ask Sarah to conclude this section with the sort of the how this works for South West London. But Annette, if I could go to you first.
Thank you, Mike, and I'll be brief. So first of all, I just wanted to just also say something very briefly about digital exclusion, and just to reiterate what Charlotte has said, is that it's not always the people who you think, so I think that we have some preconceptions about digital exclusion, and I think there's a whole new category of patients who are becoming digitally excluded, and that's because of the cost of living crisis that we're having, and I think people are struggling sometimes to maintain their digital connection because of that, and I think we need to find a way to reach out to those people as well. Then on the NHS app, I think this is crucial for patients. I think this is absolutely how people will access NHS services, and I think it can take a huge burden off our services as well. And Nicola will know that we have a huge number of queries from patients in primary care on a daily basis about appointments in secondary care, and I'm sure secondary care has something similar around their own appointments, and possibly even to do with primary care aspects as well. And so I think there's a huge benefit that we can reap there, but also I think it is beneficial for patients as well. And I thought perhaps that this might be an area that the VCS, the voluntary sector, could help us with, actually, is to increase the patient understanding of what the NHS app can offer, particularly what it will be able to also offer in the future, and to help us to reach people who we otherwise may not have that information or be easily able to use the app. And then Jacqueline made a very good point about our own staff and perhaps not always being open to digital change. And I think, Jacqueline, that's a really, really good point. And I think we need to be looking at that. We need to show the benefits to our staff of using digital technologies and digital tools that we have, and we need to do that in a sympathetic way. Just as it's not easy for all members of the public to engage with digital solutions, it's not always easy for our staff either. And so I think we need to concentrate on that to get this used as widely and as beneficially as possible.
Great points, Annette. Thank you. Vanessa.
I was just going to build on the point that Annette and Jacqueline have made around the importance of taking our staff with us on this journey, and actually a question about whether there is a way that we could use digital to support the development of staff skills around integration and knowledge around that. So whether there's a way that we could kind of kill two birds with one stone. I haven't got the answer to that, but I think there's some development work that we need to do that could take people further on this journey, as well as giving staff some very basic skills, because there is some basic skill knowledge we need.
Great points. Thank you. Martin, over to you for sort of final comments, and then I'll come to Sarah.
Yeah, okay, thanks. Just sort of doing that in reverse. So in terms of skills, I mean, a part of the workforce program across South West London will need to be about enabling digital skills for the workforce. But also there's something about how we do digital transformation. So the Digital Pioneers program, we've got 40 new people who are going to go out and preach what we do in terms of utilizing digital in and how we work. So and have a network across South West London to do that. And my ambition would be that becomes a regular program of work, and that we start to really create this strong network of people across South West London who've got some understanding of how digital can drive benefit. in terms of the NHS app, it is one of the top priorities nationally, and to be the front door for the NHS. So the more we can build behind the NHS app, the better, to be able to direct people to the right services, and effectively and efficiently, I think is kind of the priority for us, both as ICS. At South West London level, but also regional and nationally. In terms of digital exclusion, yes, there's lots that's already been done South West London on that. We're working on with that. There's a London strategy that's been developed, so we want to make sure we align with that as we develop ours. But I guess we have to recognise that we can't ever be 100% digital. If you think about banks, there is still a few banks on the high street, not many, but some people will just never be able to use digital, so we have to accommodate that. In terms of people who access care outside South West London, obviously within the London patch, we can see that there is expansion of this around the London borders. So we are looking at whether we need to expand it into Surrey. It's also a conversation in Essex and Oxfordshire and etc., because London does take a lot of people from the home counties, so we've got to expand that. There's also a conversation started around how we connect up all of these regional the regional care records across the country, because like London, other areas have got them as well. So I think, over the course of the next couple of years, that'll probably happen. And I think I covered everything there. But I do recognise, Nicola, you do need to have good basic IT to build upon, and there is enormous amount of innovation going on in primary care at the moment, which is really exciting, at the forefront of innovation, really. So thank you, Chair.
Martin, thank you for that. And I'm absolutely sure that we'll come back to this issue. Really great to hear about the digital pioneers, and looking forward to meeting them on Friday. And certainly on that point about sort of the Outer London, if there are issues which it would be appropriate for Sarah and I to raise with our opposite numbers in Surrey Heartlands, we'd be happy to take a brief on that and discuss. Okay. We can also have a conversation with their counterparts in South East London and see if there's anything we need to do with Kent and Sussex as well, so that we capture sort of our core areas, particularly, that's important in terms of the tertiary services that we provide across for the whole of South East England. Sarah, over to you for final comments.
Yeah, so all I would say is, notwithstanding the issues around exclusion, which I think were discussed appropriately in that discussion, digital is hugely important for us going forwards. This is obviously a huge priority for the NHS and care, because there is a very positive impact on our services and for patients. I mean, you mentioned banks. I can't remember the last time I entered a bank, because you do everything online, don't you? And much of healthcare could actually be delivered online, and there is lots of opportunity around that. So there's a huge opportunity there. I was really impressed by the amount that is going on. I don't think people realise how much is actually going on already. So I think it would be really useful for Martin and Matt and the team to think about how we communicate the work that is already going on widely, so that people can find out for themselves. And I'm sure they would be very happy to talk about it with members of the board should they be interested. So I think we can make that offer out to members of the board. And then I would just say that I think this is a subject that we will be bringing back, and we ought to be thinking about digital in all the items that we talk about on transformation as we go forwards. And just thank you to the team, because I think we are in a much better place in South West London than we were in the past. I think there's a huge amount of work gone on to get us to that place. And, I think the team are doing a really good job in trying to bring all this together, which is quite a complex environment, can I say? When you look at London, outside of London, all the digital companies, all the different types of services that we deliver. So, it's a big ask as well.
Fantastic, Sarah. Thank you for that. So I'm asking the board to note the progress in that area, and I'm sure that you'll join me in thanking the team and looking forward to future presentations on other areas of progress. We're going to move to a couple of items now before the break, which are truly exciting. They're part of our review of our governance architecture, and the first of these, Helen, is scheme of reservation and delegation. Make this exciting for us.
Yeah, that's very exciting. I will bring together all of the different documents to try and do this as one section. So as you'll be aware, the business rules effectively for the organisation are set by our standing orders, our standing financial instructions, our scheme of reservation delegation, and the detailed scheme of delegation. And these were originally approved on the initial meeting on the 1st of July last year. So obviously written in advance of us coming into being. So we have lived and worked with these and worked under them for the last year. And so not only is it good practice to review them on an annual basis, but actually being our first year of operating, it's really important that we see and look at how they work for us and they help us and support us in guiding us to make informed decisions as we go forward. So we've done a lot of work consulting with key stakeholders across the organisation and the system, as well as using our lived experience of working within them, particularly around the Finance and Planning Committee, the Audit Committee, and our experiences also as an exec team in our senior management team meetings about what we do and how we work. And as a consequence of that, we brought a proposed set of changes for review to the Audit Committee that have then been recommended onto the board for today. So just to give you an overview of what we've looked and reviewed, if I start with standing orders, we've looked and reviewed at that, and actually we feel those are fit for purpose. They are aligning to how we're working on what we're doing and covering our business rules. From the point of the standing financial instructions, we feel that was just a minor clarification around staff and their roles and responsibilities, that we put intact changes within the documentation, but actually broadly aligned to exactly what we're doing and provide good governance. When we got to the scheme of reservation and delegation and the detailed scheme of delegation, we had a really detailed review, and this is where our lived experience, I think, really comes into play for the last year. And we wanted to simplify them for the user. So we have done a complete format change, but also say, why do we need two documents? Let's bring them together as one, so there's one place for people to go and to use and to refer to. And so what we've tried to do is reflect the ways that the ICB's workings within it and established and what we need to do to make sure that the limits align to what we do and what we're working as a business, and simplify some of that. There were lots of very different limits within the old documentation, which got very complicated for people to use, and some were at odds with each other, one could say. To update for the new governance and processes that have been put in place by the government during 22-23 that obviously aren't reflected in the old document because those have overtaken what we've done, and to update for ICS responsibilities. So within the previous scheme of delegation, there wasn't any reference to actually what we would do and how we worked and looked at things on behalf of the system, rather than just potentially, if you like, as a CCG and as a commissioning organisation. So I apologise because I couldn't change all of that, because we did fundamentally change the way that the document is written, but we have done all the cross checks to make sure that nothing has been lost in the movement between things, and hopefully we've made it a simpler document for people to review and understand. But if we take these forwards and you're happy to approve them for us to use, we'll obviously then put a big education and briefing process in across the organisation to ensure that everybody then is understands them and is able to use them. And then we would look to come back to review when the procurement law limits change in January next year. But I'm happy to take any questions.
Helen, thank you for that. And I know these things are a mammoth piece of work. If I could first of all go to Martin as the audit chair, because I know that you've dived into the detail of this as part of your committee scrutiny work.
Yes, thanks very much, Mike. I think the bringing together the scheme of delegation is a really good piece of work. We did go through that in a reasonable amount of detail. I think the important changes are summarised in the covering paper, so I won't go through all of those. It is worth highlighting, I think, a couple of things that came out at the audit committee. So we're moving in terms of contract approval and contract limits, moving from annual limits to contract life limits, which I think is a very sensible change. And actually, in terms of contract signing, adding in the CFO and the COO as contract signatories, which gives the whole process more resilience. Previously, we only had the CEO able to sign contracts, but other changes are summarised in the introductory paper there. The other point that Helen made that I think is really important is how we roll this out and communicate the changes around the organisation, and then ensure adherence to the scheme of delegation, which, as Helen said, is the focus now. But yes, we had a good go through this at the audit committee and wanted to approve this, recommend this for board approval.
Martin, thank you for that, and we do note the recommendation. If I go to Sarah first, and then we'll take a couple of contributions from our non-executive members. Zara.
Thank you. I wanted to check with you, Helen, whether you have looked into how we can improve contractual payment arrangements with the voluntary sector. We've got huge problems across the sector at place, but a system as well with delays in raising PO numbers, in payment of invoices, even when you have PO numbers. They seem to be taking months, and that really limits the ability of the sector to work with within the NHS. So it's really worrying us.
Helen, do you want to take that, please?
Yeah, so apologies for that, because that shouldn't be the case, and we need to rectify that within this and the work that we're doing within the organisation, and part of the additional controls and reviews of controls we're doing. That should be improving. But I think maybe if we take it out of here and you can give me some examples that I can then review and see if there's any themes in there that need addressing, or whether or not they're individual instances. But I'd happy to do that and to follow up on those things.
Thank you. Dick.
Thanks, Mike. Wanted to endorse what Martin said. Sarah's point, that's really interesting, and to be borne in mind by the Finance Planning Committee going forward. Wanted to thank Helen and her team for this, and have a very quick go at saying it is exciting, this, because the experience I think we've had on the Finance and Planning Committee is the complexity and the lack of alignment has tended to encourage people to think of this as an administrative process. And of course it's not. When we're signing off new things, what we should be doing is seizing that opportunity to raise quality and to focus on cost effectiveness. And that's got drowned out by this complexity. So I think the really excellent work that Helen and her team have done are an opportunity for Chief Execs to actually tell that story across the system about that's what we're doing here. We're taking these re-procurement moments to make a better NHS and actually to better make sure we pay voluntary and third sector on time so they can be part of it as well. So that's what I think is exciting.
Thank you for that, Dick. Really, really helpful. Mercy.
Yeah, just a quick comment, and recognising that the scrutiny of equality and diversity is brought back to the board and not delegated to the Quality Oversight Committee, and I think that's correct, and that should be where it lies. So just to comment though that we will also in quality and performance be looking at equality and diversity. So we'll still be scrutinising it, but I realise that it should be the responsibility should stay at the board.
Great, thank you. It sounds like you've got a lot of endorsement there, Helen. Can I just check formally from our accountable officer Sarah that she's content with the changes?
Yeah, and in fact, really happy, because I think one of the issues is that we probably inherited some quite complex systems from the previous organisations, and this is a real chance to kind of simplify it and make it straightforward for us to run. So really happy. Think the team have done a really good job again. So, but we will review this regularly. So every year we will bring this back. So we will test it again this year.
Great, thank you for that, Sarah. Helen, big thanks to the team. We know that this was a mammoth piece of work, but hopefully it will actually make life a lot easier. And bearing in mind Dick's point, it will actually make it easier to make good decisions as well, for the benefit of our population. So Fantastic, thank you. We have one more item before the break, which is an update on the Finance and Planning Committee terms of reference. In line with good governance practice, we review these terms of reference on a regular basis. Dick, over to you for the changes.
Thanks, Mike. Just very briefly, so the first thing it does is it aligns the committee with those spending process decisions we've just discussed. We slightly reduced from 8 to 7 the minimum number of committee meetings, just so that we can better align with the audit committee. And we found during the year that would make for a better decision-making environment. The two things I'd flag up, I suppose, is the importance of strategic system reviews, which we're conscious that really needs to be part of this going forward, and the fact that we keep open the question of membership. And the more we haven't cracked this yet, so this is sort of future work, the more we can find ways to make all partners feel that the agenda can be something that they own and they want to be part of, the better. And that's something for the future that we do still need to work on. This is a helpful step forward, really turbocharged by the work in the previous item.
Thank you for that really strong endorsement, Dick. Can I check that everybody is happy to agree with the new terms of reference? Really good, thank you. We promised a comfort break at this point, so I propose that we take a 10-minute break and reconvene at 11:20. So see you all at 11:20.
It's not red wine.
We'll restart the meeting. Welcome back, everybody. I hope you're feeling suitably refreshed. We'll move on to item 9, and this is the feedback on the operational plan, and I'll pass across to Jonathan to talk us through this item. Jonathan, over to you.
Thank you very much, Chair. So
you're muted, Jonathan.
I don't think,
no, I can hear him.
I don't think I am. So can I check? Can colleagues hear me? Can some
Yes.
thumbs up? Oh, universal. Thank you very much. So I'm pleased to say this is the drawing to the close of the planning round. This is probably the final step on the journey relating to the planning round to provide the board with feedback we've received from NHS England on our proposals that we've submitted. And frankly, it's really important we come to an end point because we need to get on with in-year delivery, which is where our focus is now and moving forward. The board will be aware that at the start of the planning round, we set out some of the national expectations that have been set for the NHS for the financial year that we're in, and we'll also be aware through updates they've received as we progress through the journey to finalise our plans. This is a joint report from Helen and myself, and I'll come to Helen in a moment to talk through some of the financial elements of what's described. You can see in the paper that NHS England have confirmed that we're meeting the national expectation, or planning to meet the national expectation in a number of really critical areas for our patients. So those include recovery of urgent emergency care, performance, reducing the number of patients waiting a long period of time to access elective care, meeting the ambitions for accessing cancer services, and continuing to improve the number of people who can access a diagnostic test within 6 weeks. So there's some really important measures that are very key to our community, where there's firm recognition that our plans are fully aligned with the national ask. There are also some areas where, and the board is aware of this because we've raised these issues before, where there's NHS England are noting our position that even though it doesn't meet in entirety the national expectations in their views. So one of those areas relates to mental health, where we're planning to meet 3 of the mental health targets but not the other three are set out nationally around out of area placements, perinatal access and children and young people mental health services, though I should note we are planning to make significant progress in those areas over the course of the year. The second is a query on whether we're delivering the level of elective activity that is expected to ensure that we receive the elective recovery fund. We think we are, though I would caveat this is heavily influenced by the industrial action and the impact that's having at this point in time. And of course, we can't plan for the industrial action in any great degree of detail through an annual planning cycle. And then, of course, as Helen's alerted the board to before, delivery of the planned financial deficit, which is in line with expectations agreed with NHS England. So that's a brief synopsis from my point of view, Chair, of where we've got to through this planning rounds. And as I said at the start, now the focus is on in-year delivery and securing the outcomes that we've set out for patients. And at that point, I'll hand over to Helen, who might want to add a little bit more detail on the financial elements.
Thank you, Jonathan. So I guess within the feedback that we received, it was recognised that in light of having a deficit plan agreed with NHS England, that we were asked to take some actions to put some additional controls and financial controls in place across the whole system, across every single NHS organisation within it. Actually, as part of our financial recovery plan, we have already got what we've called our three-pronged approach, which is grip and control, a focus on efficiency and productivity, and then a focus on transformation to support us returning to a break-even position. So within that grip and control prong, we had already gone ahead and put in additional financial controls and processes and reviewed them. And actually these align to those that were in the feedback from NHS England. So what you can see in the pack is that we've already done a maturity assessment of how well those are embedded, so we can continue to focus on those and continue to develop and improve them. And that has been overseen by the Financial Recovery Board, and will continue to do so. We're looking to do another review in Q2 around seeing how much further we've managed to take that and embed them. So actually NHS England did come back to us last week to ask for assurance that we have put these measures in place. So I need to respond back to them, but just to assure the board that we are doing and working on those, but they are the requirement of NHS England to do so. And also just to note that they are also included within the updated scheme of delegation that we reviewed earlier. So we made sure that they were within there as well, so that we covered that off within our business rules. Happy to take any questions.
Jonathan, Helen, thank you very, very much for that contribution. The operational plan represents a huge amount of work having for the ICB team, but particularly for our trust colleagues. And a big thank you to everybody that's been involved in this. I know this has been a particularly challenging year, but I think setting the context, Jonathan, particularly around the ongoing industrial action, is very, very relevant for all colleagues to hear. Can I take any questions or points at this point? I mean, I'd be very keen to get a sense of the timeline for meeting the perinatal access targets and the assurance around that, not least because of the impact upon child development and consequent life chances with the failure to access perinatal mental health services. I don't know whether, Sarah, you want to pick up on that, or whether that's something Vanessa might want to speak
No, I'm
to.
happy to come in afterwards, actually, if Vanessa wants to come back and answer that. I know we've made it, we're in our plan, there is a major improvement, but I'll let Vanessa answer that one.
Yeah, I can answer that. I mean, I think we've done a really hard look at the mental health targets, and what we wanted to do was make sure that we presented something that was achievable for the 3-6 boroughs, but also stretched us enough. And I think it was became very evident, didn't it, Jonathan, through all the work that we've done, that to achieve all 6 this year was not viable, but certainly we would hope to be in the place whereby next year we were able to complete all 6 going forward. And this does sit in line with the work that we've agreed as a board through the mental health strategy. So I know it's disappointing, but I think it's disappointingly realistic, and will put us in a much stronger position for next year's delivery.
Thank you for that. No, Ruth Dombey may want to comment further on this when she introduces the ICP paper, not least because of the priority we're attaching around children's mental health. Sarah, did you want to speak at this point?
Yeah, I just wanted to mention the elective recovery fund because due to the industrial action, actually nationally, they have changed some of that. So there's a 2% change in the elective recovery fund. We are just working through what that means. And I am sure that there will be ongoing, you know, as we get ongoing industrial action, that will be reflected by the national team. That doesn't negate the need for us to still try and do as much as we can on elective recovery in order to get waiting lists down, because that's actually the most important point for patients. But we can't ignore the impact of the industrial action. I mean, over 5,000 appointments have been cancelled in South West London so far due to industrial action, and that, you know, that is difficult to make up, and we have more industrial action coming. So so there's a financial impact, there's a patient impact, and there's a kind of operational impact on some of these things. So I just thought I would flag that as a ongoing issue that we will need to take account of.
Thanks for that, Sarah. I wondered if Joe and Jacqueline would like to say just a couple of words, not least because both the operation and financial challenges sit very squarely with our acute hospital sector. So if I go to Joe first, because we haven't heard from you today, and then I'll come to Jacqueline.
You know, so I think, you know, we've been heavily involved in the production of these plans, and I think, you know, we're all working closely together to make the best of what is quite a challenging situation, Mike. And I think we've got further opportunities to sort of work together to help address, you know, the challenges we're facing. So absolutely signed up to these and committed to deliver.
That's good to hear, Joe. Thanks. Jacqueline?
Not a lot more to add really, apart from it's not only not great for our patients, but our staff are getting pretty tired and exhausted from this. And I hope we can find a resolution soon.
Thanks very much indeed. Are people content to note the feedback on the operational plan? Great. So we'll move on to the South West London ICP, Integrated Care Partnership update. Ruth, you are the co-chair of that group, so over to you for your updates.
Thanks, Mike. And I've got some really interesting and I hope exciting stuff to share with you all. I mean, you'll all be aware that we've been working on our strategy for some time, working out what are our key priorities. There's a real sense now, a drive that we need to get on and start doing stuff. The strategy document is important and it's going to be signed off. Everyone's had the opportunity to contribute. There will always be things that perhaps we'd like to do differently and better, but it's a living document and we can do that as we go along. What we need to do now is to move into the action stage, and that's what the conference that we held was all about, the 24th of May. It was really great to see around 300 people attending from a huge gamut of different organisations, groups and people. And we came together to talk about what practical actions we can take to drive genuine change. We've got our 6 priority areas that you're all aware of. Workforce challenges is very much the priority for year 1, but also about reducing health inequalities, preventing ill health and promoting self-care, supporting needs of children and young people. And I do want to come back to that, especially from the mental health point of view we've just been talking about, but also a positive focus on mental well-being for everyone and community-based support for older and frail people. And it was really interesting to see the various workshops. All participants were allocated to one of these priorities, and we had 2 co-chairs for each work stream, someone from the local authority and also an NHS chair. It was a really interesting and exciting day. day, and if I know life isn't always about bottoms on seats, but a lot of people stayed to the very end, and it was a long day with a lot of hard work taking place. Since the event, the workstream co-leads have been working hard to distill the feedback from the conference. We want to turn it into a set of collective priorities, collective actions that everyone feels that they have ownership of, that they've helped to produce, and decide how we want to take forward. And we want to focus on a manageable number of actions that will really make a difference, but also where we can build on the work that's already taking place across the partnership. I have the benefit of being on this board, so I hear about the really important pieces of work. We've been talking about digital. I'm going to come back to that again, but there's a lot of work going on around skills across the partnership, around digital and all the other important issues we're talking about. We really want to emphasise the importance of community empowerment, and we absolutely recognise the key role of the voluntary and community sector in this, and the important role that Health Watch can play. So we'll be looking at this work tomorrow when the partnership board meets tomorrow evening, and we're going to be agreeing the subgroups that will oversee implementation of the strategy. We've got a short video we'd like to show you, which showcases some of the work we've achieved at the conference. And then, Mike, I'd just like to say a few words about the very rich and useful feedback I've had since the conference that I think will be of interest to everyone on this board. So I'm going to hand over to the clever techie people who are going to set the video going. This is an opportunity to do something very different, to bring together all of us from all different parts of the community, all different sectors, different people and different voices. Today has to be meaningful and it has to have purpose. Above all, it needs to be about action.
I think what's really exciting about this partnership event is that we're bringing people together from public sector bodies, the NHS, local authorities, voluntary sector, but also real community people as well, and thinking about how we can work together to really improve the health and well-being of people living in South West London.
We've got more than 200 people gathered here today, all of them bursting with ideas on how we can work together and make a real difference for the health and care of the population in South West London.
So we sometimes, I think, as professionals assume that we know what's best for patients and for local people, but actually we have to listen to what they have to say to us about what they want and what they need, rather than us telling them what we're going to deliver.
For me, it's really important that we get across the community voice, because we are the community and we are representatives of the community. Whether you're looking at things like long-term conditions or health inequalities, we have the voice of the community, and it's really important to hear that voice, because you can't meet a need unless you know the need.
In terms of looking at inclusivity with young people, in terms of diversity, and I feel like, you know, as a collaborative, we can genuinely make that change for the long term.
The more that we can prevent people becoming unwell, the better it is for them. They can enjoy their life more, but I think we can only really do that if we work together.
Yeah, I feel like my opinions have been listened to today and also respected.
The main thing is, you know, it's all great saying that, oh, we're going to make all this change, but is actually doing this change. A lot of it is to do with funding, but there are a lot of ways, you know, with getting sort of volunteers, people who are more than willing to help young people, and even young people themselves volunteering and helping out. It's just everyone helping everyone, I think, which is a very important thing.
The message I'll be taking away again from today is we've just got to keep thinking about how we can release focus and attention and resources towards prevention and helping people live independently.
I honestly think this is a once-in-a-lifetime opportunity to do things differently, but we can only do it if we bring together the voices of everyone in the community, not just the people that we're used to hearing, but everyone, because this is about all of us. This is about our young people and their future. This is about our older, more elderly residents and what they want from us. We need to honestly talk to people, listen to people, understand what matters to them, and understand how we can actually put it into practice and make it happen. Thanks for that. The IT worked beautifully, but for some reason with my setup on my Chromebook, all now I can see is a blank screen. So Mike, can you hear me okay?
Yep, you're loud and clear, Ruth.
Perfect. Okay. Just a few things I want to say, and then it looks like I'm going to have to come out and come back in again. Isn't IT a wonderful thing? I think that video gave a sense of just the diversity of the people that were there, and I was so pleased to see young people there too. I think that's an absolute triumph. It's important to have all members of the community, I recognise, but to have some young people there made the discussion about young people and their mental health so much richer. The feedback I've had, I'd just like to share with you quickly because I think it's relevant for all of us. Lots and lots of positive feedback. People saying that it was so good to see people in a face-to-face event. The networking was really worthwhile. It was great to see everyone in person after a very long time. And someone came up to me after the event, shook my hand and said, I really feel I'm being listened to. And I was emotional then. I'm emotional now because she then told me her own personal story. And I think that's an absolute sign of success. We had very positive feedback from several of the working groups, particularly the Children's and Young People's group. But quite a few of the participants said that it connected them with several key players within health who otherwise they wouldn't have met and who are already working, in this case, to tackle young people's mental health from a different perspective to their own. I think we can't underestimate just how important it is to bring different organisations together. We assume that everyone thinks like us, uses our jargon, has our way of thinking, and that isn't true. So we need to find many, many more opportunities to bring people together so that we can understand each other better. Others said that it gave them an insight into the mechanics of the health sector and how they might be able to engage better in providing support for people and how better to access funding to develop their charities' work. Again, I think we underestimate just how complicated many people find this system that we're creating. And I know from this time that I've been on the board that I'm beginning to understand it better, but it is very, very complex. They also said it, on the Children and Young People's group, how great it was to hear from young people directly themselves about their experience and their insight into the issues that they're facing and the sort of responses that are needed going forward. And they said they thought there needed to be more events like this with a specific focus on particular work streams, in this case, young people. And I think the subgroups are going to be a good place where we can have that conversation and think about how we can make it happen. There is some learning for the future, and it wouldn't be a good event if it wasn't the case. There are a few logistical issues that we can easily fix. There was a comment about the green agenda. Some people felt it was ignored, and I was interested listening to the item we've just had on digital, how actually we didn't make that connection with the importance of the digital agenda on the environment. Jacqueline mentioned her experience as a patient. I'm going to do it too. Could everyone please in primary and secondary care make sure that all your printers are set up so that you're printed double-sided? I think we could reduce the consumption of paper within the NHS in Southwest London overnight. As a patient, I get so many letters which are single-sided, and I don't think it's giving the right message. I've also, like Jacqueline, I'm using the app as a patient, and I've said specifically I only want digital, and yet I'm still getting letters. So there's something there about how we're sending out a message to people who are using our health services about the importance of the environment and how digital fits into all of that. Some people said there's too much NHS jargon that people working in the NHS aren't familiar with. I absolutely understand that. I know in my field in local government, we try so hard to make sure that we're using human everyday language, and quite often people say, what are you talking about? We don't understand. So it will be an ongoing battle for all of us, and I think that's about listening to people and giving them the opportunity to put up their hands and say, hang on a second, I don't know what that means. Some people thought that some pre-reading would have helped, and I thought going forward when we do this sort of work, and I'm thinking more with Charlotte here, let's think about how we can give people some prep. They don't have to read it, but it might help going forward. And my last point, feedback from the workforce development group. They felt it was dominated by staff who are very focused on terms and conditions, and I'm not criticising anyone here, but it does show me just how difficult it is to bring together people who are very much on the front line and work with them to think about the bigger strategic issues. We do want to think about a new way of integrated working as we go forward. And it was interesting, I actually sat in on some of the work on that group and saw just how difficult it was to bring together that everyday operational frontline concerns with the bigger picture that we're trying to create here. But it was a really positive start, lots of learning, lots to be done for the future. We're at the beginning of a really exciting journey, and I'm looking forward to carrying on with the journey. Thanks, Mike.
Ruth, thank you for that. And I think you captured perfectly the enthusiasm, the commitment, the passion, the excitement from the event. Take a couple of points. If I could go to Zara first and then bring in Mercy.
Thank you, Michael. Thank you, Ruth. That was a fantastic summary. And I love your comment in the video about it's all about action. It is all about action. So how are we going to make sure that the voluntary sector is included going forward to make and create real change? So if we want to shift to prevention, as some people were saying in the video, through the voluntary sector, we need to make their involvement more practical, I think. Some of the organizations that attended the event really benefited from the networking. They met people they wouldn't have met otherwise. They were really, really happy about that. But some of them also felt that they were, taking part in a conversation that was not going anywhere. The other point I wanted to make is workforce development. Again, I was in that session, and yes, it was really difficult from a voluntary sector perspective to keep bringing in, our side of things on the table, because of course there were a lot of other colleagues in the room that were coming from an NHS perspective, GP perspective, and I think the South West London strategy really needs to embed the voluntary sector in the workforce development chapter in a way that we can actually contribute. I provided a lot of examples of ways that we can contribute, starting from being part of the training academy everyone was mentioning. We've got loads of training that NHS professionals can attend, and vice versa. We can support with, find local people, for local jobs, which was one of the priorities as well. So there is much, we can give, but I didn't quite see it in the report that came after that. And finally, the green agenda is so important. And I think going forward, we need to find a way to really embed it better in a practical way. We had quite a few environmental groups that were really, really, enthusiastic about the event and really struggled to find their place within it. But going forward, we can maybe embed it in a more kind of action-based type of activity.
Sarah, thank you for that. I'll come back to Ruth's sort of final comments and then ask Sarah to wrap up with how the ICB executive will support the ongoing work of the ICP. Mercy.
Yeah, just to say that I found the event really positive, actually, and to see integrated care in action, to meet so many colleagues across health and social care was really kind of uplifting for me, because of often as a non-exec, you're not kind of experiencing this on a kind of a day-to-day basis, and how important it was to get those kind of voices in the room, and also just to say that we were worked very hard. It didn't let up in my workshop, I have to say. Maybe that's something to do with John, I don't know. But yeah, so I think we put a lot of effort and certainly got kind of different voices across the system. So I found it very useful.
Mercy, thank you for that. Ruth, any final comments that you'd like to make?
Thanks, Mike. Just a couple. So, Sarah, I absolutely agree with you, and you and I have had this conversation. I'm going to be talking tomorrow about your idea for the partnership board to think about how going forward we can do some sort of market stall event so that we can actually bring the voluntary groups to us and help our NHS colleagues understand the power and the value of the work that's already being done. I was really struck by those apps that we were talking about in Wandsworth. I'm not sure that the various voluntary groups that are working specifically with people with learning disabilities, working specifically with people with dementia, know that good work that's going on in Wandsworth. So some of this is about sharing good practice, but it's very much about the voice of the community. And if I pick up quickly the point that was made before about children's mental health, I'm sure you're all picking up, I certainly am from teachers and head teachers, that we've got a real problem. Partly it's the post-COVID. Young people, children are struggling to come back to school. We have a problem with school absences in my borough that we've never had before. I'm not saying it's on a major scale, but it's certainly a growing problem. And I'm hearing some teachers in year 7 year groups saying that they still haven't seen some of our children. And while quite rightly, people like Vanessa and others are focusing on CAMS, this is also about tier 1, tier 2. This is about how we can give support to our youngsters. But inevitably, the young people who aren't coming to school are almost certainly the young people who actually need most to be there. So I think we've got a real issue. And I just wanted to mention to you, Vanessa, that Health Watch, certainly in my borough, and I would guess in others as well, have done some really interesting work around children's mental health. I was at a presentation of the Sutton Health Watch just last week. They actually did a piece of work on children's mental health pre-COVID, and so now they're able to go back and use that as a baseline. And I'm sure Alyssa can help to pull together some of the work that the 6 Health Watches are doing and just provide some richness, some real voice of people to the issues that we know exist.
Thank you, Ruth. Vanessa, did you want to come back in on that?
Yeah, I think so, if that's okay. Alisa, it would be absolutely fantastic if you could pull together the 6 work for the Health Watches and we can collect it on it. And we use mental health as a catch-all term for all different mental health difficulties. And I think this is one of the key challenges. I'm delighted that South West London ICB has agreed that children's mental health as a totality is its main priority, and we're going to be really ambitious for that. We've got some really good plans starting to be worked through. But Ruth, I think the work that we could do collectively around community resilience, understanding, and the support that we put in for our children and young people to create futures for tomorrow is absolutely essential. So the work with primary care colleagues on tier 1, tier 2, the lower end, is absolutely essential to get upstream on this. And that's certainly where our work and thinking is in place.
Vanessa, thank you for that. And whilst you were speaking, Alisa committed on behalf of Health Watch to pull that work together. So that's great news. Jacqueline.
Thank you, Mike. So firstly, thank you. I wasn't there at the time because I wasn't here, but it looks like it was a great event. So thank you for that. And I absolutely applaud. And we need to make sure that if we don't start changing where we put our focus now, we'll still be where we are in the next 10 years. So I think that's absolutely right. I was quite struck though about the comment about young children and young people. We know that Andrew Murray started doing some work on mental health in schools quite a while ago, and it sort of hit a couple of schools, but it didn't get, I don't think it got broadly looked at or rolled out in any way. And I don't know whether it worked or not either, but I think there is something about absolutely how do we work differently with children and young people, particularly in schools. And I suppose the question is, was there an impact from that? And if there was, rather than trying to reinvent the wheel, can we not roll something out, or are we clear what we need to do differently? And I'm very keen that we don't have 64 million targets to hit, that we also keep this to a few narrow things.
Vanessa, I won't come back to you at this point on the basis that I think we need to have a feature. It's an ICP priority. The board needs to come back with a substantive item around children's mental health at a future meeting. That feels like it would be both appropriate but also desirable in terms of what people would like to be discussing. I'm going to hand across to Sarah for just some final comments, but I just want to say a big thank you for the team, Charlotte and team, for the work in organising what was a major event and a really successful event. Actually, I particularly like the choice of location, which actually indicates, which was Wimbledon AFC, which is a community generated initiative which was started entirely by local people in response to the big money men taking away their football club and putting it in Milton Keynes. So it was a testament to community action. Sarah, over to you for final comments.
Yeah, and can I just say on the children and young people, actually it did roll out to nearly all the schools in South West London, and and I think actually bringing something back on what's happened and whether that's working and what we've learned would be really useful. So I think we will agenda that. ICP meeting tomorrow. So we have a board meeting tomorrow evening. Just to remind people, it will be a public meeting. It's virtual because of the train strike that's happening again tomorrow. So please do, if you're not part of the board, please do watch and listen to the live stream of the board tomorrow evening, where we will be signing off that plan and also the delivery kind of mechanisms to deliver that. So and just on the kind of practical from our team, we are supporting both the board and the work streams and how we take that forward along with our colleagues in local authorities and others. We've also committed, as we know, as an ICB, to equalities funding and funding to support the priorities of the ICP for the next 18 months in order to deliver some innovative schemes. So we'll be talking about that as well. So really positive kind of, let's move this work forward now, because we've now kind of had the workshop, we've agreed the strategy, and now is the time to deliver. So really, really good news.
Sarah, thank you for that. So we'll move on to item 11, which is a series of board committee updates and reports. And we'll go first of all to the Finance and Planning Committee. Dick, can I ask you to give us highlights of the recent meetings?
Thanks very much, Mike. Yes, now this committee meeting was back end of May, so a lot of the finance numbers have moved on, and they'll be addressed and more up to date in the next item. Just to say briefly, we continued our process of deep dives, really good discussions and some great presentations from officers on prescribing, where we spend about £500 million across southwest London. It's relatively low, making savings probably harder to squeeze out, and top opportunities, antidepressants and diabetes related drugs, points to the sorts of transformation that we're likely to need. So these deep dives helpful. We had a similar one on Wandsworth Place, a huge number of initiatives. I suppose the question always on my mind is, how will we know that we've succeeded? How different will the world be if we get all that right? Just on finance, a couple of numbers to flag up now. We were 72% over on agency cost, and that really points to some of the challenges we have built in this year. The £210 million saving plan, let's just think about last year's saving plan, where we got all but 23% of it, and 33% short if we look at recurrent. It just gives a sense of the scale of financial pressure that we've got within this year's budget. And so the commentary that Helen gave earlier on GRIP, on productivity and efficiency, and I think most of all on transformation, really important going forward. And that's why the Recovery and Sustainability Board, whose minutes are part of that, is going to be a key part of our success in the year ahead. So those are some highlights, Mike. Back to you.
Great, thank you for that, Dick. And I will go to Helen now to give us a very brief update on the current financial position. But we need to bear in mind this will only be reporting on month 2, and actually the big challenge comes further in the financial year. Helen, over to you.
Thank you, Chair. So just an overview of month 2. We are in line with plan, except due to the additional costs for industrial action that have been incurred to the end of May, and that's around 1.8 million. Also, to note, as Sarah said earlier, we've obviously had to cancel a number of operations, etc. And so that's reduced the amount of income that the trusts are able to earn through the Elective Recovery Fund, because that's all on a variable rate. And so that is £2.4 million down at month 2. However, whilst we're waiting for the final guidance from NHS England around how we will address that and the impact of industrial action, we have held that £2.4 million within the system in the ICB position, so it's showing an equal and opposite surplus to the trusts, and therefore isn't actually affecting the position at this moment in time. Then key things to note, we have got our workforce is higher than our plan at month 2, and we continue to work on that and focus on it to ensure that we've got the right for workforce and that we're focusing on reducing agency costs down. Although actually the cost her whole time in agency is higher than that in the plan. So again, we need to further investigate that, and we have got work streams as part of the financial recovery programme to look at that. And then the key things is Dick has alluded to is obviously we have got a £210 million savings plan that starts to really kick in month 4, and so as the level of savings required to be delivered really steps up at that point, and so that provides probably our largest risk to delivering the financial position. So we really need to focus on that and the financial recovery plan to support ourselves. And obviously we have got the ongoing impact of industrial action at this moment in time, which is increasing costs.
Helen, thank you for that update. I don't propose having a discussion at this point on the basis that it is so early in the financial year, but it's very good to be reassured about the current position being on plan, which I know isn't the case across much of the rest of London. We need to see what happens as the months progress, particularly as the challenge gets sharper after month 4 and onwards. We'll move on to Quality and Oversight Committee, and if I could ask the Chair, Mercy, to provide us with a few highlights.
Yes, certainly. We met on the 13th of June. We did a deep dive into community paediatrics, which is quite timely, really, as we were talking about kind of children earlier. Just to note that there has been an increase in serious incidents and in infections, and of course the pressure of the strikes was noted. I just wanted to kind of highlight in the report the 52-week wait has grown by 50%. A lot of that in one particular hospital and around children in particular. And that is due as well to the lack of paediatricians and people kind of available. So just some of the stresses in the system. Remarkably, our A&E performance improved on the 12-hour wait, and I'm sure Jonathan can comment on that as well. So yeah, pretty packed agenda. Also looked at kind of safeguarding of children annual report, but that goes back to 21-22. So the previous CCG kind of report for that.
Mercy, thanks for those highlights. John, as our medical director and executive lead in this area, would you like to add anything, drawing of our attention to anything in the report?
Thanks, Mike. I would just like to draw attention to the work that's been undertaken on safeguarding, please. NHS England sort of produced a letter sense checking what we were doing around this area. This would be the ICB response, which we discussed in detail at the committee. Safeguarding is a hugely important subject, and it's one of those things, if you get right, you get a lot of things right. And I was pleased to see that there is an awful lot of positive work going on from an NHS perspective, but more importantly, safeguarding is one of those areas which cross covers and connects into local government. So whether it's a SEND inspection or anything else like that. So it's one of those areas I would be really keen as a medic that we prioritise and talk about going forward, because if we get it right, we really are looking after the most vulnerable folks in our society. But it was pleasing to see that we think we are on top of most things without being sort of wishing bad luck on ourselves going forward.
Thank you for that, and I think you're absolutely right to highlight the importance and centrality of safeguarding, and indeed it is a partnership issue between ourselves and our local authority colleagues, who are actually the lead authority in relation to safeguarding. So it may well be something that we ask the Quality Committee to look at in further detail in partnership with our local authority colleagues moving forward. We'll move on to the performance report, and if I could ask Jonathan again to highlight any key issues that you'd like to bring forward that haven't been mentioned to date.
Thank you very much, Mike. So the three positive ones I'd like to draw the board's attention would be, firstly, telling people whether they have cancer or not within 28 days. It's a key target nationally. It's called the Faster Diagnostic Standard, and we were doing one of the best in the country at that, and have now sustained it for a couple of months. So that's really good. Similarly, on diagnostic access, now we're doing the best we've done for a long time, and over 90% of patients get access to diagnostic tests within 6 weeks, which is very positive. And from a health inequalities point of view, learning disability health checks. I know Sarah in the Chief Executive report will talk about the mental health checks, but the learning disability health checks are also exceeding the national ask, which is really important for a vulnerable group of the population. The 3 areas of challenge I was going to mention have all been already covered in this meeting, Mike, but just to say what they were: the industrial action and the scale of impact that is going to have, and as we move shortly into the consultant action, the impact on the elective pathway as well as the urgent emergency care pathway, and then next week the radiographers action. The point Mercy's made about long waiters, and strongly linked to my previous point on industrial action, how that gets more and more tricky to deliver what we need to deliver and maintain our position as one of the best performing ICBs in the country and one of the best performing systems in London around elective access. And the third, again, Mercy's mentioned, the whilst we do reasonably well relatively, I think that's as charitable as I can be, on our 4-hour performance, the length of time patients spend in emergency departments, be that for physical or mental health reasons, is just not okay. And there's a lot of work going on through the Urgent Emergency Care Board, through conversations between chief executives about what the right answers might be to deal with the step change in mental health pressures that we've all been seeing too. So that would be my 3 major positives and 3 major challenges at this point, Mike.
Thank you for that, Jonathan. I think that gives us a good a summary of the key challenges that we face moving forward. I'll move on to the Audit and Risk Committee report. And Martin, I know you've already reported on one of the substantial items which we took earlier in the agenda, but there is other work that the Audit Committee has been undertaking. Over to you.
Yeah, thanks very much, Mike. So the other focus at the recent Audit Committee was the review of the annual reports and accounts, and we've said before, 22-23 was a complex and difficult year because it was split into two bits. First quarter as the CCG, and then quarters 2, 3, and 4 as the ICB. So a lot of hard work for everybody involved to produce an annual report and accounts for both of those pieces, for Q1 as the CCG and 2, 3, and 4 as the ICB, and to have our accounts audited for both of those too. So we've reported before that there was a clean bill of health on both sets of accounts from our auditors, and the Audit Committee, as you know, did recommend for approval to the board the annual reports and accounts for both of those periods. The other thing to say is we received at the last Audit Committee meeting our internal auditor's annual opinion, which was reasonable assurance for the year 22-23, which is effectively the second of 4 tiers of assurance, which is pretty good given it's our first year of operation as the ICB, and the internal audit program of work is underway for this year as well. And yes, mentioned the review of the scheme of delegation, standing financial instructions, standing orders earlier on. Thank you.
Martin, thank you for that. I think that was a really useful summary, and I think it is good to get a sense of the richness of the work that the Audit Committee does and how important it is in terms of our overall governance and assurance. We'll move on now to the Remuneration Committee. I saw that Ruth was able to rejoin us quite some time ago. So Ruth, over to you.
Thanks, Mike. So at our last meeting, we considered 2 confidential staffing issues. Mercy was also part of that discussion, so I don't propose to go into detail of those in an open meeting. Thank you.
you for that, Ruth. We now move on to Chief Executive Officer's report. So Sarah, over to you for the highlights from your report. It was a really great report to read as well. Thank you.
So thank you very much. And I'd love to say I'm going to take it all as read, but there's some really important things in there. And I have got an additional point to add where I've just got some recent information on measles. So I would like to add that onto my report verbally. So firstly, I do need to say thank you to all of our staff across South West London who are dealing with the industrial action. This has been really difficult. We have managed, but I would like to highlight that this is an ongoing issue for us in the NHS, which is not only a problem for patients in cancellations and dealing with reduced services in trusts and other parts of the NHS, but also in the ability of our staff to carry on kind of covering for what is now a long-term issue. Today is the first day of the consultants' strike. Next week we have a radiographers' strike. The consultants have already announced another strike in August, which will be very close to a bank holiday. So it's an ongoing issue. I need to say thank you to everyone. At the moment, you know, our encouragement from the NHS is please could the parties sit down and have a further discussion, because this does need to be resolved, because it's having a massive impact on everyone. So I just wanted to say that on industrial action. On good news, physical health checks for severe mental illness, can I just say thank you to our GP practices. This is a fantastic achievement. The amount of increase is significant that we've had around these physical health checks. So I just thought I'll leave you to read that, but you know, it's really, really good news. I will leave you to read the right care, right person model, but I would like to just draw everyone's attention to the workforce plan. You may well have seen this in the media. This is one of the first times in recent years that we've had a workforce plan for the NHS, which actually ensures that we have a plan for particularly for additional training places and for working differently across the NHS. It doesn't include everything. So we are excited that we now have a workforce plan for the NHS. It's not a system plan. It doesn't include everything in the NHS. It certainly doesn't include local authorities. One of the things that we have raised for London is whether or not we should actually be looking across health and care around different types of roles. I have mentioned this to colleagues and I have mentioned it to the regional director. As you know, Mike, I also mentioned it to the minister earlier this week as well. So I do think there is huge potential for us to use this as a springboard to actually not just look at what needs to happen in health, but also to think differently, both in South West London and London wide, about what we might do differently around our health and care workforce in order to ensure some sustainability and differential ways of working going forwards. I wanted to also just mention the weather and health preparedness, just because we are in the middle, as we know, across Europe and the US and China, of severe heat, and we did have to deal with last year some severe heat which actually impacted on some of our infrastructure and how we worked. We are now, as an ICB, a level 1 responder. We are working with the mayor and others to make sure that we are in the right place within all our organisations to be able to deal with future levels of heat. And our lead on sustainability is Helen, but our lead for EPRR is within Karen's team, so it's actually Ben Luscombe, who you all know, and they are working together to make sure that we as a system are in the right place to be able to respond. And then I will just add my verbal update on measles. So you will know that measles has been in the media recently, particularly in London, because we've seen a significant rise in the number of children with measles, and actually they are a big percentage of them, I think it's around 30%, are actually quite ill and have had to be hospitalised. So it's quite a significant issue. In South West London, we generally have higher levels of vaccination rates than other areas. But what I wanted to do is just set out for you what we've done since recently in order to kind of address the MMR in particular. So we wrote to all GP practices last week to offer them support and additional staff if they needed it, if they were getting more approaches by members of the public and families around the vaccination. GP practices are routinely inviting people back in for their vaccinations. We've also worked with PCNs primary care networks to offer additional vaccination clinics. So we will be doing that over the summer. And we've also worked with the school vaccination services to offer additional vaccination clinics over the summer period. We've been in discussion with all of the local authority directors of public health, and we're working closely with them. We're offering training. We're going to be offering immunisations for students returning from university in September. So we're doing a number of things, including we're getting some communications out on this, and we'd like to thank all parts of the system for supporting us in this. So the more we can do together to increase the level of vaccinations, the better for everyone. But I just wanted to assure the board that we are doing a great deal of work in South West London to make sure we do everything we can, both to support general practice, to offer additional clinics for children, and also to make sure that everyone's aware of what's going on. Thank you, Chair.
Sarah, thank you for that. That was a sort of great summary, and thanks for drawing out those particular issues from your report. I know some colleagues are keen to ask some questions or want to make some points as well. So I know that you're happy to take those, Sarah. So if I could go to Ruth first of all.
Thanks, Mike, and thanks, Sarah. Really good report. A couple of points I wanted to make. First of all, on right care, right person. I've been having a lot of conversations with both the Met Commissioner but also our local police about what this looks like in practice. I think the way the announcement came out was a bit unfortunate, but we will move on. Their point, which I know we'd all agree with, is that if someone is having a serious mental health crisis, the last thing we need to do is to send someone in a uniform and bundle them into a police car. We all recognise that, but we also recognise that in an emergency, we need a frontline response. And we don't have a lot of alternatives at the moment. The point they're making to me that I wanted to share with you, and we need to go away and think about this, isn't so much about who is providing the initial response, although we could argue a police officer in uniform isn't the right person, but it isn't so much about who is making the initial response. It's what happens when that person is taken to a place of safety. And the point they're making to me, in particular, when people arrive at A&E or whatever part of the hospital system that they're coming into, if there's a possibility to make that whole handover process to healthcare professionals smoother and especially quicker, that would solve the problem. But having police officers sometimes having to stay with that person for 10, 12, 14 hours, we'd all agree isn't a good use of police officers who, as we know, are just as struggling as we are with constraints around workforce. So I just wanted to share that, and it's something we need to go away and think about. The other point about climate change, which you made, Sarah, which I think is really important. Some of us, like Sarah and myself, we have family in Southern Europe, in Italy in our cases. It is absolutely shocking what is happening there. And I don't think living in this country, particularly if you look out the window at the moment, we really understand the scale, the impact of what's happening, which is why I wanted to go back about the comments we've made about our environmental agenda. I've seen data that across South West London, it's carbon emissions from our buildings that actually have far more impact on hindering us to reach our net zero targets. It's far more about buildings than it is about cars. Obviously, transport is important too, but both local government and the NHS could be doing so much more to think about the impact of our buildings and how we can reach our net zero targets. And I know that on the partnership, there's a real drive to start thinking about our buildings as assets and what more we can do together to ensure that we are playing our part in reducing net carbon. So it's something to think about going forward. I appreciate that maybe my point about printers and paper is seen as, you know, a tiny drop in the ocean, but lots of drops make up the ocean. And I do think we need to show in our actions, small things and big things, how we're going to make a difference. Thanks, Mike.
Ruth, thank you for that. I'll go quickly to Sarah for a response, then I'll come to Jacqueline.
Yeah, so I'll just come in before Jacqueline on the right care, right person model. I know if Vanessa were here, she would want to say that that obviously it wasn't dealt with in the right way, as you say, Ruth, but actually the relationships on the ground with the police and the NHS and others is good. So there are good relationships on the ground. On the issue of a safe place, number one, I don't think A&E is necessarily the safe place for people when they're having a mental health crisis. However, we do recognise that when somebody is having a mental health crisis, they may also have a physical health problem. So we have been working together across South West London with all the chief execs of both the Acute Trust, Vanessa and others, to think about how we respond to that. So we are developing a plan to have co-located access to mental health and physical health with the A&Es, so that we can actually respond when the police do have those issues. We absolutely understand that this is not something that the police should be dealing with, so we're not trying to say that that's their problem. However, we need to make sure that we can find a way of dealing with this, also because it shouldn't be an A&E problem either so often. So, you know, we kind of need to find a way of making sure that people are getting the appropriate support in the right way, and trying to develop something that helps us to deliver both that mental and that physical health support to people that need it. So we are working on that, Ruth. We are thinking about how we do that, and we hopefully will have something implemented quite quickly in order to develop something across South West London that will help us.
Thank you for that.
And just on
Catherine,
the green bit, can I just say on the green bit, we absolutely agree with you, Ruth. Absolutely, 100% agree. And you know, we brought the initial plan on our to South West London, but I think we do need to keep bringing that back and keep those conversations ongoing. So
great, thank you for that, Sarah. Jacqueline, your hand went down. I suspect that Sarah covered a lot of it, but if there's anything you'd like to add, because I know this is a major issue for all of our ED departments.
I think just to say that the majority of mental health patients we get in ED do not need physical health support. Some do, but not a lot do. And when you have an ED that's 50% full in your major department of mental health patients, your physical health patients then begin to also have problems, because we're not actually dealing with that, which is what we're set up to do. So we have to look after these patients. We have to look after them in the right place with the right people. So we're all committed to that. And it's just, as Sarah said, quickly trying to find a route to do that that helps.
Great, thank you for that. Elisa.
Regarding the right care, right person model, can you comment whether or not there's an independent evaluation in place or planned for, especially one that will include the voices of the people who are actually receiving this service?
Sarah, one for you.
Right, so so number one, I think this has only been done in one other part of the country, and it wasn't done in this way. So I'm not sure how much evaluation there is, and it took 2-3 years for them to implement. So I'm absolutely sure that as we start to think about how we work with the police and how we implement any kind of changes to a model, that we will evaluate the impact. It was given to us at very short notice by the police with no previous discussion. So we haven't been involved to that extent. However, now we are working really closely together. The police are working with the London region of NHS to make sure that we are aligned, and also across the local government organisations. So we will, I'm sure, be evaluating all of the implementation of any kind of changes to the way in which we work, and we will be working in order to make sure that the most important thing is that we have the right support for people, particularly when they have mental health problems. Thanks.
Thank you. Thank you for that. We'll close the meeting at this point. I haven't been alerted to any other business. Unless there's any other urgent business that people feel they really must raise, I will close the business and remind you that the next part 1 meeting of South West London ICB will be on the 28th of September in Kingston at the Guildhall. We'll now move on to questions from the public, and as I said at the beginning, we're unable to, our technology doesn't permit us to take any questions from the public live, but we have had one in advance, which was from Wendy Micklewright, which asked when the ICB plans to ban electroconvulsive therapy, and Vanessa has agreed to provide a written answer to that, which will be duly circulated with the minutes of the next meeting. So thank you all very much for attending today, and very much look forward to seeing you soon. As Sarah said and Ruth said, please remember that tomorrow evening we do have the ICP board meeting, and those of you who are not members of the ICP, it would be great if you could join us and observe the meeting and see some of the really exciting ways in which we're going to take forward the strategy that has been developed. So I hope to see many of you tomorrow evening, but thank you all very much for today's meeting. and see you all soon. Bye-bye.